In a moment, I'll quickly run through the plan for the next 60 minutes or so, but first I'd just like to introduce myself and the rest of the panel. My name's Melissa Donald. I'm a retired small animal practitioner based in Ayrshire. I'm a former BVA council member, currently elected RCVS council member, and currently RCVS senior vice president. I was previously chair of the standards committee. I'm joined by Linda Belton, an equine vet who's been in first opinion practice in Wiltshire for around 30 years. Linda is also an elected RCVS council member and is current chair of standards. Alongside us, virtually at least, is Eleanor Ferguson, our registrar and director of legal services, and Gemma Kingswell, our head of standards, plus one or two other members of the team on hand to keep putting coins into our webinar meeting. I'll start shortly with a very quick overview of the undercare journey so far, then hand over to Linda to talk us through the key changes in the new guidance, together with explanations of the all-important exceptions and exceptional circumstances. Some of you have taken the opportunity to send us questions on these things already, so we plan to cover these as we go. Then Gemma will discuss some of the issues that have been raised around mutual clients, and Eleanor will wrap up with some detail about how the new guidance will be enforced. After that, we aim to devote the rest of the session to your questions, so you'll be able to type them into the Q&A at that point. Now, we'd rather everyone focused on the presentation first, please, rather than be busy typing away, but do keep a note of any questions that spring to mind as we go. Time is limited, but we will do our best to answer as many as we can, starting with the remaining ones we've been sent in advance. If by the end of the evening we haven't got to your question, we'll have a slide with contact details for the advice team, so do please follow up with them directly. And we're also collating some of the most frequently asked questions, along with practice scenarios, and some of which are already published as additional resources on our Undercare webpage. So how did we get here? The journey of reviewing undercare and provision of 24-hour emergency first aid and pain relief has been a long one. Its origins dating back to Vet Futures in 2016, which was a joint initiative between the RCVS and the BVA. The new guidance agreed by the Standards Committee and RCVS Council therefore reflects the findings of this thorough and wide-ranging review, taking into account all of the consultation responses, as well as other information gathered, such as the findings of independent research projects and legal advice. Details of the review process are available on the RCVS website if any of you would like to take a closer look. Developing the guidance has been far from easy, but we believe it not only protects animal health and welfare, but also maintains the public trust by ensuring that decision-making remains firmly in the hands of individual veterinary surgeons and works for all sectors of the profession. It contains a number of safeguards to address areas of wider concerns like antimicrobial resistance and misuse of controlled drugs, and sets out a framework to assist you in exercising your professional judgment. It also provides a degree of future-proofing so that the profession is prepared for the inevitable development of technology. The guidance comes into effect on the 1st of September, and Council has committed to a review after 12 months. It's available to read in full on our Undercare webpage, alongside the additional resources I've just mentioned. And you'll also be able to access an on-demand recording of this webinar and the previous one via that page in due course. Just before we continue, after the last webinar, we had a question regarding the use of extemporaneous drugs, starting with when they needed to have a physical examination before use. A physical exam is just one of the factors that needs to be taken into consideration when deciding on the choice of any medicine to be prescribed. The guidance lists factors which make it more likely that a physical examination should be carried out, and one of these is the cascade. It is for the vet to decide, using their professional judgment, what the most appropriate medicine is for the condition being treated. If the medicine is an antimicrobial or controlled drug, then a physical examination is required in all but exceptional circumstances. For other medicines, it's up to the vet's judgment, and they may decide, after considering the VMRs, that an extemporaneous medicine is the appropriate choice and can use their judgment as to whether or not a physical examination is necessary, having taken into account all the factors in the guidance. So I hope that clears that up a little bit more. So take another sip of whatever your beverage of choice is. Ignore your messages for a bit. Remember to jot down any questions for later, and I'll pass over to Linda to talk us through the new guidance.
Okay, thank you, Melissa, and welcome everybody. So what I want to do is look at what the guidance means in practice and for all species. However, I'm going to sort of focus more on the sort of majority areas of clinical practice. And it's not that we've forgotten or not considered other species areas of practice, because the guidance does have to be one set of guidance for all of us. But that's going to be the focus of the discussion this evening. Questions. Going to endeavour to cover as many of the pre-submitted questions in this piece as possible. So hopefully that will cover off most of those. Where we're not, we will then move on to some of those when I've finished, and Gemma and Eleanor also, and make sure that we really try and look at the context into which they relate. Carrying on from Melissa's comments from the last webinar, thank you to those who provided feedback, especially those that came directly to the college. We really appreciate that. And it's been really useful. And we've also looked at some of the chatter as well. Melissa talked about how this guidance was developed, and it was really developed with a big consultation with the profession, which hopefully a lot of you were part of, either contributing individually or through stakeholders, which you may be members of, BVA or whatever. And we know there was tension in the answers. Different people in the profession wanted things to look differently. And really interestingly, there were also tensions within individual answers. Well, I've no idea who, the whole thing was anonymous, but there were times when people were saying it must be like this all of the time. Oh, actually, but not one or two times. And I think what we've learned from the feedback is around the issue around the prescribing of antibiotics in companion animals or non-production animals. And what we'd like to do, and this is going back and is going to sit with the Standards Committee for review, is make it such that a physical examination is always required prior to prescribing antibiotics in a non-production animal. However, it can also be prescribed based on test results taken at or just after the physical examination. The exact wording, we want to make sure that it may be appropriate, for example, a urine sample from a cat. You can't take that at the time of your physical examination, but that the results of that provided by the owner would still enable you to prescribe. And we also want to make it possible, because we've been made aware of different, taking into account different working patterns where people work different days, or even if you're just going off on holiday or if you're locuming. We want to make it possible for a colleague who has access to the test results and the clinical notes from the physical examination to be able to make that prescription when those culture and sensitivity results come back. Or the same might apply if it was an antiparasitic and you'd taken a sample for analysis to determine whether there was anything, and if so, what, and then what you were going to do. And I think hopefully that will have answered many of the questions. The whole rationale around this is around getting good veterinary oversight around the prescribing of medicines where there is potential for resistance development or environmental contamination. And that's where we want to take that to. So we still keep that requirement for the physical examination, but have a more practical and easier to manage approach to a subsequent prescription, such that we do promote good prescribing practices. So as I say, the exact wording of that's still to come, but thanks to your feedback, and that's where that is sitting at the minute. The other thing I wanted to clear up before moving on is around some confusion around POMVs and POMVPSs, where I didn't make it clear enough that the VMRs and hence the guidance only relate to POMVs. So if you are looking at, and the commonest would probably be around antiparasitics, a POMVPS product, the guidance does not apply. So if we go on and start to look at undercare on the next slide, looking here at what the key changes are. When we are asked as vets to take an animal under our care, it can be the owner or the keeper of the animal, and we can choose whether to say yes or no. So we're asked and we're going to say yes. We will take these animals under our care. After we do this, we have to be able to now provide on a 24/7 basis the ability or have the capability to physically examine the animal or visit the premises of these animals taken under our care, and in a time frame that is appropriate for the needs of that species that we have taken under our care. Now, we don't have to provide this necessarily ourselves. We can have that provision provided by another veterinary provider, but the key difference here is it is up to us, vet to vet, to sort that provision. It isn't good enough just to say to a client, oh, and you better register with another practice as well. If we take an animal under our care, we have to have this capability sorted, and the agreement has to be made by us with another veterinary provider, be in writing, and be made before we prescribe medicines. We also have to make sure that we inform the client what this provision is and how they contact it, and if relevant, where it is. And the time frame in which we are able to provide this 24/7 physical service is really important, and it does realistically mean there needs to be an element of geographical proximity, as we know for some species the need could be immediate. So that is a key change for us. So then if we move on to prescribing for these animals which we've taken under our care. So if we go on to the next slide, please. The guidance lists a number of considerations. Whenever we're prescribing a medicine, we are required to make a clinical assessment such that we can prescribe safely and effectively. What that clinical assessment looks like is up to us as vets, it's our judgment. The guidance gives some things to take into account as to whether or not a physical examination needs to form part of that clinical assessment. They're listed on here. The list is not exhaustive, but it's giving an indication of the sort of things we need to take into account. So the complexity, how much background knowledge we've had, how well we know the owner and understand the situation on the premises or of the animal, and what impact any medicine we prescribe without a physical exam may have on the future in being able to make further diagnostic tests reliable. And what we're trying to really build here is effectively a VCPR. We're not looking for a form to fill in or a box to tick, and it's not something that can look forwards. It's in the moment. It's each and every time we prescribe. These are the considerations we should be taking into account, whatever the medicines are. And should also point out that this undercare guidance that's changing is only one part of our overall guidance. The rest of the guidance remains in place and unchanged. And this should be read as part of the whole guidance. So other areas that are often relevant will be around mutual clients, especially if we've got that shared provision vet to vet organised. And remember, this does apply to all species. We do have some species specific questions, which we will include as we go through as well. So very much around judgment and being able to prescribe and gain our information so that we can prescribe safely and effectively each and every time that we are looking at this. So when we've got to this point, there are obviously some exceptions around when we always need a physical examination. And if we go on to the next slide, please, we can have a look at those. The first is around if we suspect a notifiable disease. Yeah, we need to see that animal, visit the premises as appropriate, and make a physical examination part of our clinical assessment. And the other area, which I touched on briefly talking about the change, was around medicines that we use to manage infectious agents. A physical examination is required in all but exceptional circumstances before these are prescribed. And the whole rationale is around increased veterinary oversight around the prescribing of medicines where there is potential for resistance development or environmental contamination. There are differences of opinion around whether this is always required. But this is the situation that we're going to go with. There is a review, as Melissa mentioned at the start of the guidance, but we feel this is the right approach for these medicines. And hence, this is where we've landed with this. There are slight differences between non-production and production animals in terms of prescribing these. With non-production animals, it's at the time of or will be on the basis of test results relating to that physical examination. In production animals, it's a representative animal or the animals at the time of or recently enough to ensure that you have adequate knowledge and includes knowledge of data, the premises, the production systems, the health status, and all those other factors that often come into play, especially, for example, in the poultry industry, in how they prescribe their antibiotics using pathology data and so on. Key around this is also with antiparasitics, the difference between prescribing and supplying. We often talk about doing the repeat medicines prescription book and things like that. Very often what we're actually doing is supplying at intervals against a prescription. And so for antiparasitics, this would be a good example of that, whereby if we take an example of a dog, you may be having a consultation, a physical exam with that dog for a health check, a vaccination, and in that you will prescribe for a period of time of your choosing an antiparasitic regime appropriate for that animal. So long as within your notes you record that prescription. Now, this does not mean you need to write a prescription in terms of, as we say, if a client asked us, could I have a written prescription, please, for meloxicam? No, this is just within your notes, putting in the information that constitutes a prescription. And that information is the name of the drug, and you can either use the brand name or the generic name to give yourself room for maneuver as appropriate, the dosage, the frequency, and the strength. If that is all within your notes, that constitutes a prescription for that medicine. And then you can supply against that at intervals of your choosing. So you might supply in 3 monthly, 12 weekly, whichever, against that for the duration that you have determined is appropriate for that prescription. And that is fine to do. We have had the debate around growing puppies and kittens, and that is slightly more complicated because we don't want to be getting them back in. We do have clients who come and they drop in and they regularly weigh their growing puppy. And it will be necessary when you're doing ones for puppies or kittens to prescribe the different strengths that you anticipate that breed might reach in the duration. You don't have to use them all, but it means they're there. And as the puppy grows, you can continue to supply in the way you'd intended, so long as you've had that initial physical examination when you've made that prescription. So that is the thinking on those. The other exception, and I'm sorry, and I'm going to ask you to go backwards, is around the controlled drugs, and I think it's back again. Whereby a physical examination is required prior to the initial prescription. I'm not going to go into the very many details around the prescribing of controlled drugs. That is another separate part of the guidance that remains unchanged, talking about what our requirements are for those. But what the guidance changed, the relevant bit is always a physical exam before the first prescription. Again, you can supply at intervals against that prescription. You can also make one other prescription with a clinical assessment after this initial one with a physical that included a physical exam. And this follow-up one of a clinical assessment doesn't have to include a physical exam if you judge that it isn't necessary. And again, then you can supply against that. But then after that, you would need another physical exam. And then we talked about how you use your clinical notes to prescribe within them and then supply against it. So it should enable us to maintain that oversight, really meet our obligations around responsible use of these medicines in a practical and pragmatic way that's good for animal health and welfare, and we can deliver in practice. We then go on to the exceptional circumstances. So back over again, please. By definition, they're exceptional circumstances, so can't actually give you a list of what constitutes exceptional circumstances. But as a sort of some indicators, it may be things which alone aren't exceptional circumstances, but when they collide and all occur simultaneously, create an exceptional circumstances. And heaven knows in veterinary practice that does happen sometimes, or freak incidences. An example, your practice might be one side of a river, there's a flood, a bridge is washed away. The client can't get to you, but they can potentially pick up medicines by going in the other direction. It may be perfectly reasonable in those circumstances for you to make a prescription where normally you would do a physical examination, but you can't. Again, just record and justify what you've done and the circumstances around it in your notes, and that would be absolutely fine. But by their very nature, exceptional circumstances are just that. And so long as you've made a sensible decision-making process and recorded it, that wouldn't be a problem at all. And I think that's most of the things I wanted to cover in this section. The last slide I covered earlier, so hence Ian whizzed through to keep you up to pace with that. So I think I can hand on now to Gemma, who I think was going to talk to us from the mutual clients.
Thanks, Linda. Yeah, so we wanted to touch on the topic of mutual clients this evening as part of this webinar, because it's something that's been coming up since we announced the new guidance, questions around the obligations of each vet when you've got more than one involved in the care of an animal or group of animals. And these questions have been coming in the context of a remote prescriber prescribing something, and how does the normal vet know about that, or the usual vet know about that? And actually, mutual clients as a whole is not new, but it seems to have ignited questions around that area since we announced this guidance. So something that we wanted to just give a bit of a refresher on whilst we're thinking about how it applies. So essentially, what our guidance on mutual clients says is that where you have different veterinary surgeons treating the same animal or group of animals, each has to keep the other informed of any relevant clinical information. The purpose behind that is pretty much common sense. It's to avoid any danger that might arise from conflicting advice or adverse reactions because medicines are not compatible, and so on. So that's the reason why the requirement exists. And as I say, it seems to be highly relevant to the guidance that's coming into force in September. The mutual clients guidance we have at the moment does have a little bit more detail in it to do with where you have two veterinary surgeons dealing with different groups of animals, but which belong to the same owner or keeper. So perhaps in those situations, you might have one veterinary surgeon or practice responsible for the dogs and cats and another responsible for the horses, or you might have different veterinary surgeons responsible for different, if you've got more than one species on a farm, you might have different veterinary surgeons responsible for those. And where that is the case, each vet has an obligation to let the others involved in the treatment of those animals know anything that might affect the others' work. So if you notice something on the farm or the yard and you think, oh, actually that's relevant for them to know, then do let them know. The other thing that we've been asked about in relation to this is is who is most responsible. So whose job is it to let the other one know? Who has to go first? And we would say that the obligation applies to all vets involved with the treatment and care of those animals equally. So it's not just the primary vet's job to let the remote provider know, and vice versa. It's everyone's responsibility who's involved in the care of those animals to let others know any clinically relevant information. And we do recognise, however, that there are situations where you might be involved in the care of those animals and you haven't been told that there's another vet involved, but you suspect that that might be the case. So you might see medicines around that you haven't prescribed, or there might be procedures or treatment going on and you think, well, we didn't do that treatment, I wonder what's going on there. And if that happens, we would advise you to try and find out who the other vet is that's involved, so you can fulfill your obligation to share that clinically relevant information. But the obvious question that flows from that is, well, what if I get in touch with them and they won't tell me, or they don't want to share information, or they ignore my requests? And I think that's something that Eleanor's going to touch on shortly. She's going to talk to you about enforcement and how this part of this new guidance will be enforced going forward, and she will deal with those kinds of issues when she speaks to you. So I'm going to hand over to Eleanor now.
Thank you very much, Gemma. Yes, before I talk about mutual clients specifically, just generally, I think one of the points that has come up around the new provisions here is, are we going to have some sort of special powers around enforcing this part of the guidance and only this part of the guidance? And the short answer to that is no. We have to deal with all allegations of breaches of the code and the guidance in the same way, so that it's dealt exactly the same, whatever it is that people are talking about. And that mechanism is through the concerns process. And we are aware that raising formal concerns causes an element of frustration. It is a process that's involved. And I think that sometimes is heightened if it is a situation where one professional may be wanting to or considering raising concerns about a fellow professional, because there may be something of a feeling of, well, can we just not tell you about it? Can we just pass it over somehow, and you can sort it all out somehow? But we do need evidence to back up allegations. So it's not enough, and this is sometimes that we've had in the past, for someone to come to us and say, well, I've heard that so-and-so is not fulfilling their obligations, or we've heard that they are not doing this. We would need a little bit more to go on to enable to process through on a concern. And what I always say to people in connection with this is, don't think of it just about you complaining about somebody that you are unhappy about, but what would it be like if somebody was complaining about you? Because if it was so straightforward, just on a casual remark to get somebody sent to disciplinary on something that they'd heard or somebody had told them was happening, that would be the same if somebody was putting a complaint in against you. And I think everyone would agree that where we have concerns, you would all want the relevant safeguards in place, the relevant thresholds to be met and the tests to be met, particularly if it could potentially be somebody's livelihood at stake through a disciplinary hearing. So a little bit more about, well, what is that evidence? What could it look like? So one thing that Linda talked quite a bit about was the requirement to have the 24/7 follow-up, the capacity to physically examine an animal or visit the premises. And as Linda said, that is something that has to be in place, vet to vet. It has to be arranged in advance. It has to be in writing, so there is something concrete and tangible that we can ask for. It's something that we can ask to see. So if, for example, a member of the public goes and is prescribed medicines and they're told something like, well, if your animal doesn't get better, you've got to go and see your local practice. They end up chasing around half the night trying to find somebody, and they complain to the RCVS. In that situation, we've got direct evidence from the person affected. They can give us a statement. They can tell us what was involved in their interaction with the practice. And we would be able to go back to the practice and ask for that documentation. around the 24/7 follow-up to check, well, where was it and why were you not actually telling the client about it? Because that's very much key area in terms of the new guidance. But as Gemma said, one of the areas that does come up is around mutual clients. And I think this is one where it is perhaps more likely to be one professional complaining or wanting to raise a concern about another. So for example, you are on a farm and you come across a bottle of Pomvise with labels on it from another practice. You've never heard of that practice. They've never been in touch with you. You didn't know anything about them. You've no idea whether they're visiting. You've no idea of their 24/7 follow-up arrangements or anything to do with it. So first of all, you can take a photograph of the label. So you've got something tangible there that points to what might be happening. But I think the first step there is going to be contact the other practice. As Gemma said, the obligation is in all concerned. You're now aware that there is somebody else there potentially involved with this client, and ask them how you would be working together. Ask them what their 24/7 arrangements are. And it may be the very fact of that conversation or that communication resolves it. If it doesn't, if they ignore you, then I think it would be a good idea to follow it up with some sort of an email. You could be disappointed that they haven't engaged, and you can repeat the request to have that conversation about how you are going to work together with your mutual client. And if they still don't respond, you could then raise a concern with the RCVS. Because you do now have a bit of a paper trail. You've got evidence of what you've asked. You've got evidence that they are not complying in terms of the mutual client requirements. So we're starting to put together that picture that could form the basis of a concern. As Gemma said, the situation does get much more difficult when you don't have any idea who might be there. You suspect. You think there might be, say, in the same situation on the farm. You think it's likely they're getting medicines from somebody else, but there's no actual concrete labels or such like that you can point to. Clearly, you're going to have to ask the farmer. Now, the farmer may tell you, they may not realise the situation that's going on, and they may not realise or be aware of the requirements on mutual clients. They may tell you, in which case you're back to the same process as we had before. But if they steadfastly declare that there is absolutely nobody there or refuse point blank to tell you who it is, then I agree we are in some difficulties, because apart from anything else, in that situation, we would not know who to be able to raise a concern about. And that is a difficulty. And in that farm situation, obviously, you would have to consider, if you were asking to sign on any of the farm assurance scheme, if you can genuinely, hand on heart, sign up in terms of the actual wording, in terms of what you're being asked to do. And just a little word also on a slightly different topic, but again with the flavour of enforcement around it. It's around overseas vets. Because one of the questions that arose when this guidance was, I think, around, well, what happens if a foreign registered vet, so we're talking here not an MRCVS, not someone who is under the jurisdiction of the RCVS, but a foreign registered vet supplying medicines into the UK, as in, you know, sending them through the post. Well, they shouldn't be doing that. That is potentially in the territory of illegal importation, and it's something that the VMD might want to know about. And it might also be something that could be raised with their local regulator, wherever that may be, in whatever country that they happen to be in. But we do have situations where you might have an MRCVS who was based overseas. They could potentially provide services to UK animals, but they have to be on our home practicing register. They have to fulfill all the CPD requirements. They have to have PI insurance covering them. And they can't simply package up medicines and, as I said, same as with the foreign vets, supply them directly to clients within the UK, because under the VMRs, supply of medicines can only take place from a registered veterinary practice premises, which would be subject to inspection by either the VMD, or if the practice was in the practice standard scheme by the RCVS. So I think that one is unlikely to apply. They could potentially supply a prescription to be filled in the UK, but even here, they will again, as Linda has pointed out, have to look into the situation of how are they providing their 24/7 follow-up? Have they got an arrangement in advance in writing, vet to vet? It might be possible in very limited sphere, but if somebody is trying to cover the entire UK, I think it's unlikely they're going to have that 24/7 follow-up as a kind of blanket coverage. And also in relation to the medication, if it falls under controlled drugs, antibiotics, antiparasitics, etc., then there is a requirement for a physical examination, so they're not going to be able to fulfill that part of the equation. So I think these are just a number of points around enforcement in general. And I think along with the FAQs and a number of points, we'll be putting up some information to cover these. Thank you.
Thank you, Eleanor. That's and Linda and Gemma. We're doing very well. I hope everyone's still with us out there in the ether. We're now opening the question box to type in your questions in the Q&A. We will try and get through as many as we can. But in the first instance, we'll go to some, while these are gathering, we're going to go to some that were sent in earlier. So if we can have the first one, please. So how do the new guidelines affect equine practice? For example, travelling vets who treat horses all over the country as performance horse vets or consultants? Linda, I'll throw that one to you as the equine vet.
Thank you. The guidance applies to all species. So using this particular question, vets travelling long distances, seeing performance horses in various locations around the UK, they can continue to do that so long as they've always sourced that 24/7 physical examination capability / visit to the premises. So they can continue to work in that way, but the difference would be they can't just say to a client, oh, and register with a local practice if there's anything that, you know, is urgent or doesn't fit within the remit of those services that they're focusing on. They now need to make sure that when they're working on these yards with these horses, that there is provision and they have made that vet to vet with a practice that is willing to provide the cover that they can't in person on a 24/7 basis, and that the client is aware of that arrangement and how to access it.
Thank you very much. Next question is, can you cover more of how this will impact farm animal practice?
I'll keep going on that one.
Yep.
Again, applies to all species. So the big thing, obviously, with farm animal practice, you're generally visiting the premises, and geographical proximity will come into play. And it's got to be each and every time you prescribe. So under the old guidance, it was possible to take animals under your care by making a visit to the farm, and then for the subsequent months as you decided, you could then prescribe medicines to the animals on that farm because you'd taken them under your care by a visit some months back. The difference now is that each and every time you prescribe, you must be able to have that ability to examine the animals or visit the premises. And obviously for antibiotics and antiparasitics, there are the requirements around a recent enough physical examination and understanding of the current situation on the farm, or an examination of the representative animals. So that's probably the biggest change. Thinking of the last question, consultants who want to have special interest areas and travel to bring those skills to the benefit of those farms, they can still do so, so long as they have that vet-to-vet arrangement of the support if they are also going to prescribe medicines as well as provide advice.
Thank you. thank you. So the next question covers some vet nurses, and basically, how does the new guidance affect the role of the RVN? Eleanor, would you like this one?
Thanks, Melissa. I think the first thing that I would say here is this guidance is around the prescription of POMVs, and veterinary nurses cannot prescribe POMVs in their own right. Whether in the future there might be a nurse prescriber role that would allow something like this, that's a subject for another day, another topic, another debate, but it doesn't form part of this guidance. Under this guidance to prescribe POMVs, the vet, as has been mentioned already, has to have taken responsibility for the animal and have done the clinical assessment. And that assessment is whatever information is necessary to be able to prescribe safely and decide whether a physical examination is necessary. If the medication being provided is an antibiotic, an antiparasitic, controlled drug, etc., there must be a physical examination, and that physical examination cannot be delegated to an RVN. That is something that the vet has to do in all but exceptional circumstances, is the only time when a physical examination might not be required. And Linda's touched on the sorts of situations when we might be talking about exceptional circumstances. If the medication, the POMV, is not one of those specific categories, the vet still has to do the clinical assessment, and it's the vet's clinical assessment, but information provided by the veterinary nurse can form part of that clinical assessment. So the veterinary nurse could have a role to play in relation to that. I think the point's been said already around the difference between prescribing and supplying in installment prescriptions, in installments chunks, if you like. And I think the example given was around the antiparasitics. If the supply has been authorised by the vet, then there is nothing to stop the RVN dispensing the medication. But that's dispensing against the supply that's been authorised by the veterinary surgeon. And I think there was another part of another question that had come in around, is there something that is affecting telephone triage by veterinary nurses? That's a situation where we have advice being given over the telephone. We're not talking about a prescribing situation. So the situation has not changed in that from the way that the guidance runs at the moment. There isn't a change.
Thank you very much. Our next question is for, I think Gemma would be best placed to answer this. In cases where remote prescription is required due to the lack of local veterinary provision for a species, can RCVS produce a template for a written agreement between two practices regarding sharing mutual client and the provision of emergency care?
Thanks, Melissa. I think the short answer to that is no, that we don't have any plans to issue a template agreement, but the content is likely to be quite similar to the types of agreements that practices already have in place with out-of-hours provider if they don't provide their own out-of-hours. So I don't think the content will be starkly different.
Okay, thank you. Okay, the next one, I think, Linda, you'll probably be best to answer this one. Once a physical examination has been performed and a prescription made, how long before a further physical examination must take place? And how often do remote clinical assessments need to take place in between the antiparasiticides, long-term drugs, e.g. NSAIDs, controlled drugs, e.g. phenobarbital, and is it down to clinical judgment alone or are there limits? Sorry, it's a bit long-winded.
That's fine, thank you for that. How long you prescribe for is clinical judgment. That is your decision. However, in terms of the need for the physical examination, there are the differences between the types of medicines that we talked about. So with antiparasitics, you need to do that physical examination when you prescribe or post a test relating to it. How long you make that prescription for is up to you, and you can supply at intervals against it. For a long-term medication, using NSAIDs as the example, you potentially having taken all those factors into consideration that are in the guidance around relationship with the client, their knowledge, access to history notes, when the animal was last seen, the nature of the medication, the complexity of the health status and the conditions being considered, etc., you may never have made a physical examination. I don't know how often that will apply, but it is your judgment, and you may never need to do it in theory with the guidance, but you have got all those considerations to take into account as to whether a physical examination is needed to ensure that your clinical assessment gives you all the information you need to prescribe safely and effectively. Going on, in terms of reassessments, again, those can be involving a physical examination or not at your judgment. And then for controlled drugs, we've got the situation where, again, you've got the particular guidance around controlled drugs and how long you can prescribe for, and the supply issues, which are issues for the VMD as well, and that's a separate set of guidance. So there are some limits depending on the type of the drug, but most of the decision in terms of the length of your prescription is your judgment.
Thank you, Linda. Now, don't run away. The next one, I think is good for you as well. So clarification on absolute day-to-day consulting notes, prescription writing requirements for vets in primary care practice.
Okay, so that I think is around how do you prescribe within clinical notes such that you can then supply against this at intervals. And that's the comments around you have to include in your notes the name of the drug, you can use brand or active ingredient generic, the strength of the drug, the dosage and the frequency. And that information needs to be within your notes to constitute a prescription.
Thank you very much. Give you a break. I think the next one looks like a Gemma question. If you're a vet providing an online advice-only service with no prescriptions, no selling of meds, are you required to provide and arrange 24/7 emergency cover?
So if it's advice only, so as described in this particular question, then no, there's no obligation to provide 24/7 follow-up or out of hours. But there as part of the package of new guidance that's coming in, there is some new guidance to do with advice only services, and it might be worth if I just point out a couple of points that are contained within that might be relevant to this person. So the first thing is that veterinary surgeons may only give advice to the extent appropriate based on the information they have about the animal, and should bear in mind the general guidance on veterinary care and in relation to prescribing veterinary medicines. And the second thing is that where advice is given remotely and there is no ability to monitor the animal, for example, because it's provided as part of an online service, veterinary surgeons should ensure that the client understands the limitations of the service and that animal welfare and/or subsequent veterinary care is not compromised. So no, there's no obligation to provide 24/7, but it is really important that the client understands that there is a limitation to this service, and for the veterinary surgeon to only give care to the extent that is appropriate without that provision.
Thanks, that's really sensible advice. Thanks, Gemma there. Linda, as regards prescribing antiparasitics, can charity shelters be treated any differently?
Short answer to that is a no, because the rationale around it is around medicines that have the potential to develop resistance or cause environmental contamination, and whatever the setting they're used in, those are the things we want to be thinking about. So they will not, there's no difference in the impact of their use in a shelter setting than any other domestic setting. So the situation is the same.
Thank you. Oh, right. Here's one for Eleanor. How does the new guidance affect home euthanasia only providers?
Well, if the service is truly only a home euthanasia service, they would come under the category of limited service providers providing one service and one service only. In that situation, the obligation is to provide cover that is proportionate to the service that you're offering. So in theory, it would apply, but it may be that in practice, it would be less likely to apply in that situation of euthanasia only. I think, though, one of the issues when people talk about euthanasia-only services, quite often what they are actually providing is end-of-life care, kind of what some people sometimes describe as hospice care. And in that situation, they would stop being a limited service provider and become a full service provider. So the same would apply to them as everybody else. All the other situations that we've been talking about in relation to their out of hours cover, their 24/7 follow-up if they're wanting to prescribe remotely, and obviously the requirement to prescribe, to physically examine in the case of controlled drugs, antibiotics, etc.
Yeah, because I suppose some people might change their mind when the person actually goes to perform the euthanasia, and that would be why. Would that be right?
Well, I think sometimes where it has come to us in the past is that people quite often say, well, I'm a euthanasia only service. And what they're actually talking about is that end of life service. It's a little bit broader. I suppose it would be possible to have just that very, very, very niche, but I think it's going to be highly, highly unlikely.
Thanks for clarifying. Linda, prescribing for my own pets or my family's pets, but who are registered with another practice, how would that work?
Okay, so if it's your own pet that's living in your own home, you'd be absolutely fine because you've got that animal under care. You can do your 24/7 and you can physically examine. If it's a family member who is too far from you to be able to provide that undercare requirement, we talked about having the capability to physically examine that animal, you shouldn't take that animal under care and prescribe for it if you can't do that, unless, of course, they have got this relationship with another practice and you can make that agreement with the other practice that you will take these animals under your care and prescribe for them in the appropriate way, and that they will provide the bits of the care that you can't. But you should actually make that relationship with the practice with which they are registered in writing in advance, and make sure your family know that before you prescribe for those animals. So you can do it, but in agreement with the practice who are there to do the bits you can't.
Thank you very much. Now we're going to go on to this evening's questions now, and there are some which are all very similar. So apologies if your very specific one doesn't come out. And I'm going to probably go to Eleanor for the first one. It's about the mutual clients, and the big question is, where do we stand with GDPR and sharing records? Do we need to get permission to share the clinical notes every time? And what happens if the owner declines?
Well, I think one of the areas here is around where does GDPR bite, and it bites in relation to personal data, which is around people, and it's not so much in relation to animal information. There are quite a lot of complex rules around it, and rather than me trying to summarize them here, we have detailed guidance on the website around GDPR and mutual clients and GDPR in general. I think it's around section 5, 5.8, 5.9, something like that of the guidance, but we'll make that available in terms of where it is, but it's there on the website. Thank
you very much. I'm just trying to find ones which are common that are coming through here. Are practice protocols sufficient to cover dispensing situations? Oh, Linda?
I might need a little bit more
there.
Context around that to quite know. Practice protocols for dispensing. Is that supply against an existing prescription when we mean dispensing, in which case that might work fine, but I'm not quite sure what that question's referring to, sorry.
Yeah, I would interpret it that way, Linda, that it's dispensing against prescriptions that already exist. And if that's the case, I don't think anything needs to change from what the position is now. This guidance relates to the prescribing of POMVs. It doesn't affect supply or dispensing.
Thank you. Just again, sorry, there's a lot of questions here, so I'm not going to be able. We're not going to go through them. Be able to go through them all at all. In a multi-vet practice, can a second vet in the same practice who did not carry out the original physical exam prescribe the POMVs? Beth's going to answer that one as a written one. I've just seen that one. Sorry about this. There is so many of them. I'm trying to get the really important ones done. What arrangements can apply to geographical situations such as an island and peninsulas where 24/7 cover is impossible? Gemma, do you want to do that one?
Well, I think that situation happens now with providing 24/7 first aid and pain relief. So I think those vets will be well versed in kind of those kinds of difficulties. But bear in mind that there are, so for POMVs that are not not antimicrobials, not controlled drugs, it's a matter for you whether a physical examination is required. So bear that in mind when you're making those decisions. And where a physical examination is required in respect of those other medicines, there is the caveat for exceptional circumstances. So if you're in a situation where, you know, the weather's very bad, the ferries are cancelled, you know, you're really struggling to do what you need to do, then you can bear in mind those exceptional circumstances caveats, but just make sure that you make a note of whatever your reasoning is for prescribing outside of the guidance.
Thank you, Gemma. Regarding authorising parasite control at e.g. a booster time, we have to specify which product, dosage and intervals. So this means that if a patient doesn't tolerate one product, we can't dispense a different product without re-examining the patient. Would that be right, Linda, do you think?
That would be the case if the product that you've chosen doesn't work for that animal and that they have some sort of I think the word was intolerance of it. Yeah, you would, before you can change it, those would need to be seen again in those cases.
Thank you. And you did go through this, but just for clarification, could you confirm for controlled drug prescriptions, you therefore must examine the pet and then can prescribe 28 days, then a second assessment, which might not be direct exam for a further 28 days, then another exam would be required? This person seems to be a bit confused. So
okay, sorry, I obviously wasn't very clear, and there is a lot of other guidance around controlled drugs which is not changing. So the only thing that is changing around the controlled drugs is that it's one of the cases where a physical examination is required before that prescription, not the supply. So again, if you look at the 28-day issue, which the VMD does talk about recommending, is around not having lots of controlled drugs in clients' homes. But actually, there is the opportunity, I think, that if the veterinary surgeon is sure the owner is competent to use the medicine safely, you can supply some drugs in more than 28 days. But no, we're not talking about 28-day repeat physical exams, because you can supply in intervals against your prescription.
I hope that clarifies it.
If you look at, sorry, Melissa, if you look on the RCVS website, there is a separate section about guidance for controlled drugs, and this issue around the 28 days and instalment prescriptions and all of that kind of stuff is dealt with in there. So do have a look at that if that's something that's not clear.
Thank you. Going on to another mutual client inquiry, how do you satisfy the need to know current prescribing health information if the other vets aren't open to send the history at the time and it's an emergency? This person's had owners lie before saying the animal isn't on treatment at the time, but have later found out they were on antibiotics from another vet. Gemma?
Yeah, I mean, that's a really difficult one, and you know, a difficult one to manage for the vet in that situation. I think the answer is that the vet just needs to do their best to get the information that they can, and if they can't get if they think that they're not getting accurate information, then just do their best in that emergency situation to provide the care that they think is appropriate. If they're really concerned that something might be contraindicated and cause more harm than good, then maybe they need to think about what treatment they provide, if they provide any. But I think the answer is simply just do your best in that emergency situation. Sounds like they've done all they can.
Yeah, I think you can't control the clients, and as long as you've written your notes that you have asked the question and that was the answer. Yeah, thank you. That's really useful. What would happen with, for example, a wildlife hospital when they want a bottle of antibiotics, which they can then use to see fit with different animals that come into the hospital? Wildlife one, who would like that one?
I'm quite happy with that. The wildlife situation is akin to the production animal situation. So it's not quite you can leave a bottle of antibiotics sitting there, because that is the sort of thing we are really trying to move away from. But the wildlife situation will be akin to production animal, whereby you need to have done a recent enough or a representative, understand the situation, the health status and the setup, etc. Because we do appreciate that with wildlife there are different issues around handling. The aim is always to return them, hopefully, to the wild if possible, as quickly as possible. So then it's sitting more in that, and then not going to be in a domestic setting.
Thank you. I think this is going to be you again, Linda, I'm afraid. In a multi-vet practice, can a second vet in the same practice who didn't carry out the original physical exam prescribe POMVs?
Obviously, you can prescribe POMVs without a physical exam anyway, unless they are controlled drugs or antimicrobials. So if we assume that it is an antibiotic, that was the scenario whereby, as long as a physical exam has been done on that animal and the prescription relates to the condition from that examination, and you've been waiting, say, for your culture and sensitivity results, another colleague in that practice can, so long as they have access to the notes from the physical examination and the test results.
Thank you. One for Eleanor, and I'll probably do one more after this, because time is ticking on. But this one, when reporting concerns around other vets prescribing without the animal being under care, can the concerns be raised by an organisation rather than an individual? i.e., is there a place for an independent organisation to help vets with raising concerns? Because vets are obviously overworked and don't necessarily have the time to do this.
Well, slightly conflicting things coming through in the question, but I mean, the first point is anybody can raise a concern, be it an organisation or somebody else, but generally speaking, the person who's raising the concern is the person or the organisation that has the individual knowledge. So if we had to go and get a statement from somebody, who would we get it from? Because what you don't want to get into the situation is exactly what I was talking about, which is hearsay evidence. Somebody's told me, well, we would simply have to go to somebody else and get the information. So it might be that somebody could make an initial approach, but in order to progress it, we're likely to be back in the realms of trying to get that direct evidence, and the direct evidence is going to come from the person that has actually had the interaction. So if it's one individual who's been interacting with the practice, they've been refusing, for example, to cooperate on mutual clients, they would say, well, I sent an email, the email was sent, they didn't give me this, and that's the person that we would use to get a statement going forward. So I hope that covers the question. I hope I haven't misunderstood what the person was getting at.
Thank you. And again, this will be Eleanor or Gemma. Is the professional indemnity cover needed for a vet who provides just online-based advice services?
I would say yes, because you are providing, you're using your veterinary knowledge. So yes, I would say yes, you do.
Yeah, it's an overarching code requirement. Regardless of what type of work
doesn't matter what you're doing.
Yeah, I'm glad you answered that, because that's how I understood it, as well. So we've stretched it out slightly over to the 8:30. Thank you for bearing with us. It has been quite a speed dating on the undercare, I would say, a little bit there, but it will be recorded and you will be able to get back to access. We will also have all the questions there that we will try and get to and respond at some point, either through the scenarios or the Q&As on the website, or if they are very specific, somebody from the advice team will hopefully get back to you. So thank you very much. I think that for all joining us this evening. I hope you found it worthwhile use of your very precious time. Many thanks also to our panelists, Linda, Eleanor and Gemma, and to our behind the scenes team for keeping the meter running, because we can't do this without them. We're definitely not techie people. But anyway, again, for anyone whose question we didn't get to, really sorry. You also saw the undercare, the advice team email earlier, and we do keep looking at our webpage for the FAQs and scenarios. Thank you very, very much for attending. Please do enjoy the rest of your evening, and good night.